This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome to Audible Bleeding. Today we have a panel to discuss the impact of COVID-19 on resident and fellow education. We are privileged to have three distinguished members of the Association of Program Directors in Vascular Surgery with us. First, we have Dr. Jason Lee. He's professor of surgery at Stanford University. He's the director of endovascular surgery, and he's the residency and fellowship program director. He also serves as the secretary and treasurer of the Association of Program Directors in Vascular Surgery. We also have Dr. Chris Abularrage. He's an associate professor of surgery at Johns Hopkins. He's the director of the Diabetic Foot and Wound Clinic. He's also the Vascular Surgery Fellowship Program Director. He's the chair of the curriculum committee of the AP-DVS, and he's the editor-in-chief of the V-Score for the American Board of Surgery. We also have Dr. Lori Pounds. She's a professor of vascular surgery at UT Health San Antonio. She's the chief of vascular surgery at the San Antonio VA, and she's the Vascular Surgery Fellowship Program Director. She also serves as the chair of the education committee of the AP-DVS. Dr. Lee, we'll start with you. What do you envision the main challenges in education during the coronavirus pandemic?
Thanks, everyone. I think the major issues surround certainly providing as good of education as is possible during these times of crises. Certainly, first and foremost, I think every hospital locally is dealing with trying to make sure that they provide the best possible care for the community. And I think in our roles as educators, I think that we have to involve as safely as we can the resident part of it. I've heard a lot of things about, do you send the med students home? Do you send the residents home? Remember, they also are part of the front line of the future of healthcare. And I think seeing how we respond to this in terms of times of need is important. Now, that being said, a lot of their education is going to be altered and has been already for the last, I'd say, 3 weeks in California, and certainly likely for the next 3 months, which for the senior trainees puts them into the end of their training. So I think we just have to remember what our roles are as both doctors in our community as well as the educators for the future generation. Things have to change, and I think we're seeing it on a week-to-week basis. And I appreciate the opportunity to talk to colleagues across the country to see what best practices are. But again, also, I think we all have to acknowledge locally we're all going to have different issues that come up. And I think as a group that we just sort of remember what the guiding principles are.
I think one of the main things that we've found here at Hopkins is that, the majority of educational instruction is done as a group. And once you limit the number of people who can be in a room together and also limit the distance that they can be from each other, it becomes a real challenge. Maryland is probably a week or two behind California, but we've had to go to virtual and remote meetings for just about everything. So that's been one of the major changes. Now, for the trainee, that may not be as difficult because they frequently are more savvy in terms of the technicalities of remote learning. However, it all has to be coordinated, and not only with the trainees, but also the attendings. And that's been one of the main challenges that we've had so far.
And how successfully have you addressed that?
Well, in all honesty, it was only a couple of days ago that we sent one of our two fellows home. So we now have a week on, week off rotation for the fellows, where the fellow at home is basically on call from home. Now, that being said, what we've done is we've tasked that fellow with coordinating the educational conference. So that way they're still participating and not just sitting at home doing nothing.
And you're doing your conference by Zoom, or how are you doing your conferences?
Zoom. But there are a lot of different programs that you can do.
Dr. Pounds?
I was going to say, we have Zoom, we have GoToMeeting, we have like 5 or 6 different platforms now. And so that's been one of the challenges I think that we found, is that different people have used a bunch of different formats to do all of these different educational things. I know we have personally run into a lot of different technical problems just in that arena, because this group will use this for a grand rounds for general surgery. The military is hosting educational conferences. And so were invited to those, and that's a different platform. Some people are using Skype. Some people are using Zoom, which the free version was only 45 minutes, and that was causing issues. You'd have to send out 2 different invitations. So there definitely has been some technical issues to all of this. The logistics has been overwhelming.
Dr. Pounds, you mentioned you're on a WhatsApp chat group, and you were saying that you'd been doing remote conferences for a little bit. Is that because you have a couple of different sites at your fellowship?
Well, so some people may have experience with the VA and chuckle at this, but probably about 3 to 4 weeks ago, I guess when this first started hitting the news, the VA had started preparation mode, and we actually stopped medical student scrubbing in preparation to save PPE within the last 3 weeks. So at that time, our fellow was involved in these discussions, and I've seen the transition for her from an educational standpoint to understand that higher level. Of course, she was at first very defensive for the medical students as being part of their education, and why can't we have everyone scrub? And so I've been able to bring her in and try to get her to understand sort of that higher level of decision making and involve her in all of these decision trees. We're going to go from the VASCON chart that they have out from Toronto. We're going to do these cases. Now we're going to do these cases. And I've tried to involve the trainees into these different levels of how we're changing as it's become more and more challenging of what we're facing as to why we're making these decisions, and not making it dictatorial of why we're doing it, but a group project.
The thing I wanted to touch on, and I appreciate Dr. Pounds mentioning that multiple people have used different types of meeting conferencing things. I didn't realize that. I think some people know Zoom came out of Stanford, and so Zoom has been in our infrastructure forever. And actually, we were getting some media that, Zoom was going to go free. And I remember locally thinking here, oh, wow, that's great. The rest of the country gets to use it. And then now I'm hearing that they limited it to 45 minutes, which I can tell you wouldn't have worked for many of the remote meetings that we have had that have taken longer than 45 minutes. So I can understand that the platform winds up making it a challenge. But yeah, specifically for what we've been doing for the conferences, certainly M&M, which we do on Mondays, is all via Zoom now. A couple of us have gone into the office to do it from the hospital office if we happen to have had to do cases, or certainly whoever's on call that day sits in their office and does all the meetings via that. And then I think what Chris was touching upon in terms of the didactic conferences, those have all hopefully across the country moved to a remote platform, if not some sort of social media hangout. I've noticed that just because in California, schools have been closed for about 2.5 weeks, but the teachers are going to school and setting up Google Hangouts for my kids who basically throughout the day, outside of hearing their voices in the house, I think they're in their room on their Google Hangout with their teacher. So certainly if that level of kid can do it, then I think that all of our residents and hopefully the faculty can figure that out to still keep things on schedule. But things are changing, and it's hard. And Sharif, where you are, I'm sure maybe resident education, now that you've reached a different stage than other parts of the country, maybe it's a little less important or a little less vital right at the moment today compared to other places in the country. It's hard to give a one-size-fits-all to everybody. And I think just hearing from various folks in the APDVS and the VESS and the SVS and trying to come up with national guidelines, maybe that's not really the solution. Maybe we provide support and help and examples of how things are doing, but we don't prescribe things because we can't pretend to live in other parts of the country right now.
One of the things we learned from people who've gone through periods like this, Mal talked about his experience in Hurricane Katrina, is that you want to maintain as much normalcy as possible in these extraordinary times. And so I think the conference schedule and maintaining the regular education of the residents is very important. And so we've managed to do that pretty well with the Zoom software. Cornell has an institutional account, and so it makes it pretty simple to set it up, and it's been pretty smooth. But I think that there are some other challenges as well. And Kevin, maybe you want to ask about the case volume?
Yeah, I think as a trainee, it's twofold. We have two fears, especially as a second year trainee, really getting my autonomy in some of the more complex cases. These are really a crucial last 4 or 5 months of my training. So what do we do to make up for this? And then I think the other fear in the back of residents and fellows' minds are we going to be penalized? Are we going to start our jobs late? Do you guys have any thoughts on how to potentially help with this operative loss that we're experiencing?
I think, unfortunately, there's really no way to deal with the operative loss within the time constraints of your training. I mean, the reality is that everyone's volume is tanked because most places are no longer doing elective surgeries. And I think while I understand that it's a vast concern for the trainees, and especially those who are about to graduate, I think the reality is that with good support from new partners from wherever you go, the trajectory of being able to independently do cases is astronomical. And so I think that everyone feels that they should be ready to go out on their own on day one. And the reality is that many places actually institute a 6-month dual operative schedule to get the recently graduated trainee up to par. So while your case volume towards the end of your training may have dropped, I think it's probably not as big a concern as you may think.
Yeah, I'd agree with that. Kevin, I think that's a common and sort of appropriate concern, certainly for somebody finishing. I think that it's going to be tough educationally to provide, obviously, the exact same experience that you would have gotten had this not happened. And I think that hopefully the situation you're going to in July or August will acknowledge that. I mean, certainly no practice will be unaltered by this, meaning whatever job that you took, wherever you're landing, will also be readjusting to many things. And so I think it's unprecedented what we're all going through. We have one new hire coming to our system in August, and obviously graduating 3 people that are going to 3 different places across the country. And we're having those active discussions. And again, I think difficult necessarily to prepare for that outside of what I think vascular surgeons always do well, which is to be flexible and creative and anticipate and then execute when they need to. I think that's the strength of how we deal with our vascular patients. And now this is wild, outside of perhaps Mal Sheehan and going through Hurricane Katrina, hard for me to imagine the rest of us have ever been affected like this in our lives.
So are any of the 3 of you aware of any thoughts in terms of case minimums? I know that the American Board of Surgery had sent something out saying they're going to look at case minimums, but for our 2-year fellows, this will be probably about a quarter of their fellowship potentially, or an eighth of their fellowship that they may be doing less cases. And so will they make accommodations for people in terms of case minimums?
Sharif, I'm on the vascular surgery board currently. We touched upon it on a conference call last week. Last week is already different than this week in terms of what we were expecting. There were some other things, obviously. I'm sure everybody who's on the call and people know that we've already canceled the certifying exam, the oral boards in May in Philadelphia. That was kind of the first hurdle we had to get through in terms of lots of discussion about either options for doing that or whether we just scrap it and then what that really means. I think we have to work through those things still. I just, from my own voice, separate from the board, but from my own voice, I'd say that, I think that somebody that's on the trajectory, that's a couple of case minimum short of whatever, say 40 abdominal cases or something like that, that gets to 39 that got wiped out of 3 months, probably was on a trajectory that was fine. And I think generally the board takes all these things as individual things when there's issues that come up.
Plus, remember, once hopefully this is over, I think there's going to be a lot of cases that will need to be addressed. And so I'm a true optimist, and I really hope that there will be a great need to get cases done. And I think hopefully trainees will find actually maybe even some increased autonomy, maybe even close to the levels that we had 20 years ago, where you might run 1 or 2 rooms to try to get some of this volume through. So it may actually turn out to be somewhat of a good thing as we're trying to catch up on some of these cases. But I am an optimist.
Yeah, that's an interesting point.
I think it's always good to be optimistic, you know.
So speaking of losing this operative experience, sometimes we look to simulation as we've lost some of our open aortic experience over the years. We've moved more to simulation to help get the younger generations up to speed. But unfortunately, in the era of social distancing, it makes some of the simulation hard to do. I know one thing we're talking about doing is watching some videos together in our conferences, some operative videos, and discussing them to at least stimulate some of the operative neurons there. But do you guys have any alternatives as far as how to supplement this loss of operative experience during this month or maybe 3 months that we're out of practice?
Simulation is difficult because most of the simulation type machines are run by industry, and we've had a complete ban on any non-essential industry reps coming into the hospital. So I don't know. And, furthermore, if you look out, a lot of the regional meetings have been canceled where they offer simulation. And I wouldn't be surprised if the VAM gets canceled this year. So I think it's a bit challenging in the era of social distancing to have simulation as a supplement to operative experience. Beyond watching videos, I'm not quite sure what else could specifically be done to increase the operative experience for the trainees. And I think, that sort of comes down to the question, right? But it's a question for the VSB, not for the APDVS. But the question sort of becomes like, well, what are we going to do once July and August hit? I mean, are we going to actually require people to stay? Because some people have signed contracts for jobs already with start dates. I mean, at some point, we're just going to, my guess is, have to just drop the case minimum based on the fact that this is a worldwide pandemic. This isn't just something in one little area. It's affecting everyone across the board.
Yeah, I do think that the APDVS's role, because there is a case minimum ad hoc committee, I think that Carlos Bechara is still in charge of, that has suggested altering various things that we've talked about it at our meeting over the years. And I still hope that Dr. Reed decides to run a virtual APDVS, because I think it's these kinds of issues that the program directors need to, in a conference, discuss, so that then the recommendation then generally is made to the VSB, and then subsequently then the VSB to the RRC kind of thing. And so that's why, while we're all hunkering down and doing our own individual work, I think some of these decisions, I think, need to be made on a national group level still. And then specific, Kevin, to your question about simulation, just as certainly one of the champions of simulation for the last decade, it's impossible to do and to social distance. Obviously the Sim Center, where we do spend some time doing, various modules and suturing things for some of the junior residents, that obviously is all nearly completely on hold right now in the hospital, because hospital resource wise, we're considering the folks that work in our Sim Center, that some are retired nurses and stuff, they're all told to work at home right now. So functionally, a lot of the educational parts of a hospital are shut down right now. And I think people are preparing. We just had to make a list for the faculty of things we were willing to help with in the ICU, whether we felt comfortable doing bronchoscopy, intubation, rounding on ICU patient. We literally had to fill out a checklist just so that the department could have a list of volunteerism, if you will, and behind off mic, then I might tell you how I filled things out. But yeah, we're gonna try to be team players here. But to a certain extent, it's an odd time right now. It's an odd time, and I think that's if the message from the university and Stanford University was one of the first handful of universities across country to basically tell the students don't come back from spring break. We happened to have spring break about 2.5 weeks ago. So we basically told kids don't come back. And so as soon as that happened, the medical school dean said, okay, the med students, you're out, stay out of the hospital. That already created a whole bunch of ruckus about education being devalued. But I can only imagine what Sharif is going through in New York, because, everybody thinks, well, if it could happen there, it could happen anywhere. How much, just things that are going to have to be waylaid here. And so yeah, a simulation center definitely right now, I would say, is non-essential hospital business if you're fortunate enough to have one.
So my thoughts on it, I think simulation has two components to it. Some of it's the technical piece of sewing or modeling something, but a lot of it's also getting people to think through the operative decision making, and that's higher level simulation. I wonder if it's still possible to do that kind of stuff, because obviously you can't do stuff in person, but that's where I'm wondering if we have a pool of operative videos or something, we can do oral board type questions for the fellows and take them through operative decision making, some way to figure out an alternative to educate in this period. What are your thoughts on that?
I think that would be a really nice way to put that together. I mean, I guess if it even came down, we could do, even animal operations. If you can't get together, you could even try to come up with animal models or almost similar to the asset, even come up with cold cadavers to put together to take trainees through maybe some reduced cost way of doing this. If somebody said, I'm short on X amount of aortas or something that they were short on, I don't know how you would fund that, but if there would be some way to put something together similar to the asset trial and get together and try to do something.
I'm not so familiar with the asset trial, so could you describe it?
Okay, well, for us, for the residents that are going to want to become chief residents in trauma, assets to the American College of Surgeons, and we do, they're fresh frozen cadavers. And so my fellows participate in with that. I share the cost with the general surgery program. And so I help teach the vascular surgery exposures in certain areas. It's all about vascular control for hemorrhage. And so, I'll teach a part of it, and then my fellows participate. But what happens is the general surgeons go in and they'll learn how to do cross-clampling, the aorta or whatever exposure. But what I do is I take the fellows then on a different part of the body and, learn a different exposure. So they're working on the abdomen or the pelvis, and we'll be up looking at the subclavian, or while they're up looking in the thoracic, we'll be doing lateral exposure to the popliteal artery. So there is a way to do that.
Okay.
Maybe we could combine and, try to take advantage of those types of things at the same time to try to get more double duty training exposures or training opportunities for everybody.
Yeah, Sharif, I think it's a great idea to find videos. And I know that the SVS Education Committee, Rabi Chair, was charged with working on the learning management system, LMS, that even a lot of Chris's work on his modules were going to be put into LMS, that the videos that have all been submitted for the VAM the last 3 or 4 years, multiple people have always questioned, gosh, those videos get submitted, only about one-tenth of them get ever publicized. And then even those 1/10 that were good enough for the meeting aren't on some online thing. You could think of a creative program director at home that might then just review videos in conference with the residents as a way to, to at least have some sort of discussion point. I think that's a good way to do it. I think that videos and some of the well-made ones that the SVS has access to, I think it is a great point. And I'm going to fire off an email now to suggest that we just, all of this stuff we were thinking about doing, while people are sitting at home, that's what we should be working on, to be ready to improve it.
And they could be perhaps webinars, so it's not just one program. I mean, if it's open to fellows across the region area like that, there may be some value to that,
One of the things that we've been doing here at Hopkins is incorporating the V-score curriculum and doing exactly what you said before, which is have oral board type questions associated with the different modules that we're learning for that week. So I and my associate program director basically come up with 2 or 3 case scenarios and then present them to each fellow separately and sort of walk them through everything. And the nice thing about the V-score is it's separated into not only disease processes, but also procedure-related modules. So we try to be really strict, just the way you would in the oral board setting. So that's another option for education at this time.
I have a thought, and I'm not sure how feasible this is, but since all of us are going to remote educational conferences, we used to save the PowerPoints that the fellows came up with for their talks and they could adjust them and reuse them so you don't have to, reinvent the wheel. But if we have the capability to record all the educational conferences, including the interaction between fellows and attendings. That might be a very valuable resource. So if you're doing oral board type clinical questions, and we get the Hopkins questions, and we get the Stanford questions, UT San Antonio, and you have a large, and then people can go through them and see which one are the higher quality and share them amongst the vascular educational community, that might be a resource that you can develop a fair amount of content fairly rapidly, as opposed to just, a one-off thing. Do you think that'd be feasible?
That's a great idea. We actually did a video conferencing with UT Houston on like a Friday night. In fact, the UT Houston group was much better. They did it over, the faculty did it together over alcohol and did mock orals. Dr. Jay Kumar, my partner, arranged it with Zoom. And so their faculty were examining our fellows, and we were examining their trainees, and did a regional mock orals. And each people wrote up questions and whatnot. So that would be a great idea to do it that way, with or without alcohol.
Yeah, I think that's something that this all is a great idea that I think in this downtime, the APDVS, that would be pretty simple if somehow we just had a repository of all of our Zoom, like a schedule of people's didactic things, and the trainees across the country, as they're being sent home or being told to stay away for 4 days or 5 days or a week at a time, they could just look at the schedule and see when certain conferences are and log in and watch. I think most educators across the country would be totally okay with that. If somebody has a good connection and could just listen into our conference Wednesday, 6 to 8 p.m. and a different faculty runs it. One of my senior partners is going over visceral aneurysms. I'm sure somebody across the country could just log in and listen. I don't think there's any downside to that. It probably would have to be housed in some central list of this is the calendar. And if you want to put it on the APDVS website, here's the Zoom link to it. And you just click in as needed. You just have to, I guess you'd have to verify you were a resident or some trainee. We'd have to figure out some of the logistic thing.
I think that would be great. I do think the recording piece, if we could do that, that would be very useful as well, because part of the challenge is we're going to get overloaded with Zooms. Everybody's got conference calls all the time. But if it's done well and then it's recorded, someone can review it on their own time later. If they're studying for their boards, they can go back and look at a couple of these. And I wonder how complex it would be to just record the Zoom. Do any of you have any experience with that?
You can record any Zoom conversation. There's a button for record on the Zoom, maybe not on the free Zoom, but on the people that have Zoom within their institutions. You can record the entire Zoom interaction.
Yeah. So maybe going forward, just all the programs do that. Within a few months, we'll probably have a significant body of educational material that people can share. I do like the idea of sharing the central schedule through the APDVS also. So if I want to hear what you guys are doing at Stanford or Hopkins or San Antonio, I can just log on. That would be very cool.
Definitely.
Yeah. On the same topic of case simulation, I think it could be a really unique tool to help, get the vascular surgery community even closer knit than it is, where, say, Dr. Pounds is going to give a talk and we invite 4 different training institutions, and maybe she gives a 10 or 15 minute talk about a disease process that she deals with more frequently that we maybe don't see as much in New York, but then also goes through an oral boards, but with angio, like a tough case. And because things are managed slightly different in different areas of the country. And I think there's enough operative decision making based on angiographic images. You show a run of an occlusion of something and you talk through kind of the options. I think we could crowdsource this and then also get to meet people from around the country, because we're all doing these conferences anyways.
Yeah, that would be a great idea. Plus, again, you're right. Some people regionally, and there's different philosophies on how people approach things. There's certainly the older school way of some people looking at how they would approach it. Some people are in, economically disadvantaged places where they may not be able to get a patient back, say, to observe a wound or put them into a good wound care place where they may be more forced to do something more aggressively, and other people have good access. So that would be a really great idea. The trainees could see the different ways that in their practice encounter what they may have to do.
I think those questions, those oral board type questions, that's what's nice about them as well, because the reality is that there are a lot of different answers to each question. And if you're the person presenting the case in any oral board situation, you can walk the trainee down a different path. So, the way I may present a case to my trainees when we're doing this oral board type exercise is different than you may, or my associate program director may, or my partner may. So that's the nice thing. If we can get a repository of these types of questions together, it helps not only prepare them for the oral boards when they can take them, but it also helps them in operative decision making and also understanding the different ways to go tackle one specific problem.
Yeah, I think that's great. Maybe we should just start it after this call, start an email chain. I can write the one from Cornell and we can crowdsource this. I think it'd be awesome. But to continue on, we want to dive a little bit into some more of the COVID specific details of how institutions are reacting to this. What are you guys doing in regards to staffing? Are you guys using a piece coverage model to prevent people from entering the hospital, splitting teams? How have you guys approached this?
Well, I think it's very local, Kevin. From a surgery scheduling standpoint, about 3 weeks ago, when perhaps California jumped on a little quicker than I would have liked, but now in retrospect, it looks okay that we shut down pretty early. We were told that we had to divide cases into tier 1, tier 2, or tier 3. Tier 1 was emergent, any gunshot wound or rupture or something torn or somebody stroking out. Tier 2 had to be done within 30 days, otherwise potentially could lose life or limb. And then tier 3 was purely elective. So obviously we're only scheduling tier 1 and 2. Very quickly, we realized that the 3 hospitals, the VA, Stanford, and a community hospital that we run, we realized that the resident team was way too big because we were guessing that the volume would go down by about 70%, which was about right. So we told the folks, okay, think about it like it's the weekend. And, I didn't really micromanage because the residents, I give them quite a bit of leeway to make the schedules, if you will, to make their call schedules and make sure all the attendings have smiles on their faces and are covered. And they came up with a thing that I think they're all happy with. We have 2 interns on service and only 1 person comes every day. We have 2 mid-level residents doing consults. Only 1 person's coming every day. Now, how they did it based on whether they did a week on or week off or 2 days on, 2 days off, I left up to them because you'd be surprised. I got feedback from one of my seniors who was moving to Hawaii. So he already sent his wife and kids back to Hawaii when this was all happening about 2.5 weeks ago. He actually says he's kind of lonely and doesn't want to be home alone for a week. And so he's made arrangements with his seniors as they're covering. They're kind of going 1 day on, 1 day off. Because he says he doesn't really know what he would do in his apartment by himself for 7 days. So again, I think all these things are local, and I think we as the program directors, and I'd be curious to hear what Lori and Chris and Sharif's opinion are. I think we have to empower the trainees to also act how the faculty are acting in terms of covering each other. And then I think we can provide to other places, this is how we're doing it, and everybody can evaluate whether that fits their local politics and whether that works for them.
We, bless our heart, at the VA, they did the usual military and got rid of all the patients, but called everyone to report for duty. And so, because they're paying for the residents, sort of wanted everybody to report. So we've come up with a way to document that we're still providing a service, and we have an educational duty. So we have 1 person, 1 senior show up and 1 junior show up each day. Very minimal patients are actually in the hospital. Very minimal cases are being done at this point. We've sort of followed the VASCON where we're only doing emergent things in hospital at this point. And the veterans are being offered another clinic appointment, but if they say they want to be seen, we still have to see them on their clinic appointment. So God love them. Some of them are still showing up. The average age last Wednesday of the people who showed up was 82. I was like, why are you here? Please don't come. You should not be here, But anyway, that's another story. But what we're doing is so we're having them look up different topics, educational topics, and doing little Zoom meetings so that they're doing educational things and working on order sets. The post-amputation order set is atrocious. It's never been fixed in 10 years. So help us do some quality improvement projects while you're remote. Go over different things like that would help us make the service a better service. So we're getting them to help us do that. We haven't been able to segregate everybody a week on, a week off, which is what I would prefer to do, which would be the smarter thing to do. But we're at least getting some people away some days to decrease the exposure at least 50%.
Chris, what are you guys doing?
Yeah, so I was going to say before, we talked about this when we made the decision to do the week on and week off. Our concern with doing the every other day was that we only have one fellow per year, so it's not similar to Jason's scenario by any means. But what we were worried about is if we did one day on, one day off, that both fellows would get exposed. And that would leave us without fellows and, possibly without trainees or, even attendings being able to do things at the hospital that are necessary. So we did the 1 week on, 1 week off, and we only implemented it Monday. So we've yet to see if that works, but that was at least the thought process behind that. I will say in terms of patient visits and seeing patients in the clinic, we have quickly gone to telemedicine here, which has its own technological difficulties. But I will say that most patients, at least around here, don't want to come to the hospital when they feel that they don't need to. If you have a 3-month or 6-month follow-up for a bypass duplex and you're not having any symptoms, it really may not be worth it to come to the hospital and possibly get exposed. So telemedicine has been implemented across all departments.
Yeah, we've gone to telemedicine, and we actually had Misty Humphreys on last week to talk about some workflow advice and things like that. So if people are just starting to do it, you can listen to that and find it useful. What are you guys doing to protect your fellows? We've started talking about having guidelines for our consults that are different than in normal circumstances. They call us about a patient for AV fistula creation. We know we're not going to do it at this hospitalization. We're going to wait till the pandemic is over. And so we don't necessarily need our fellows to go and examine that patient and expose themselves. So do you have some thoughts on maybe changing guidelines for evaluation and consults for our residents in order to minimize their exposure?
We do telemedicine for that as well. So basically, we've told the emergency room that we're not coming, and neither are our trainees, for anything that can be dealt with from home. So I will say that the general surgery program director put out an edict that it's very clear that junior residents are not to be scudded to go scope out consults because that puts them at risk. But what we've asked the emergency room to do, depending on what comes through and what their consult is for, is to allow us to order testing without seeing the patient. If there's a foot wound or something like that, they Skype with us so we can look at it. And what we've created is a daily morning urgent outpatient visit. Basically, the idea is if someone has some diabetic foot wound that really just isn't that bad, they get sent out on oral antibiotics and they're seen the next day in the urgent vascular clinic. And that's covered each day by a different attending who's basically the on-call person anyway for that day. I think it's important to really limit the exposure for our trainees, because if you think about it, a consult goes out, the junior resident goes and sees them, then the fellow goes with the junior resident, then the attending goes with the team or with the fellow or whatever. And that's multiple people being exposed for no reason whatsoever.
How about you guys, Jason and Lori? What are your thoughts on that?
Yeah, no, I totally echo everything Chris just said about what you realize is how much ridiculous consults we have been getting for the past 20 years of my life, that actually a lot of it can and should be done over the phone or through some pictures and then getting an ultrasound or CT scan. So yeah, I totally echo that. Whoever the person going down to make the evaluation should be somebody, if you have to do it in person, should be the only point of contact to the patient potentially, just to minimize exposure, and should be somebody senior enough to be able to make an adequate assessment. That's an important thing. A month ago, the intern on service was getting sent down to learn how to do an ER consult. That clearly is out of the question now. Now, whoever's in the hospital that day doing consults, we're trying to tell the ER, if it's not something that we're going to deal with for 30 days anyway, then we would just set them up to be seen in clinic in 30 days. I can tell you, because I was on call the last couple of days, we've been called down there for a cold leg, for a clotted dialysis graft, for a couple of trauma, and then a couple people in chest pain with dissections. And that's really been it from the ER, which is way different than the usual, well, I was just down here for a cough and I happened to notice that I actually have leg pain when I walk 2 blocks or something like that, which the ER happily calls us for every day.
Agreed. Same thing here. Just trying to limit the number of people, limit the number of everything, and the patients, except for some veterans, the patients have auto stopped coming. I love my vets. I do.
All right. As we wrap this up, like Dr. Pounds, I think we like to think in the positive here. And I think there's opportunities for improvement of services and different things. So how can we use this time to better ourselves as people and as surgeons? You guys have any ideas and thoughts on how to use this to make things better?
Well, to make things better for society is that's a very global thing. To make things better for training and the logistics, I'll give a couple of things because I'm just on a group chat, just me and our 12 trainees, and I'm just reminding them, hey, you know what? During this downtime, great time to study for your RPVI.
That's
and
what we're doing.
Checked out. Great time to log all of your ACGME cases. A couple of the folks that had abstracts onto the SCVS that got canceled, I said, well, I'm happily waiting for the paper so you could finish the paper. There's a bunch of books out there still being done and chapters needing to be written. And I'm sure Chris could, if the now would have been a great time, Chris, for people would have had no excuses now to not submit things back to you. Let's take care of some of those academic things that I think we've all procrastinated slightly.
I wholeheartedly agree. Organization from Dropbox to Canvas, so that the people on Canvas can see it, and then taking it to SharePoint so that the people can all get to SharePoint from the other Surge Learning portal. And we're going to try to make it all work together. That's what we're going to try to do. I told you I cursed an IT god, and I've been stuck. I'm like Sisyphus or somebody, I've been cursed somewhere.
I think using this time to do academic pursuits is really an excellent idea, and it's what we've tried to institute as well. Sending our fellow home for the week doesn't mean that they're just home. They're work from home. So just because you're not doing surgery doesn't mean that there are other pursuits that need to be addressed. And so we're making sure. The Rutherford chapters all went out. I mean, I've got my home fellow starting her chapter and working on the first draft. Other things that have been sort of in the queue but haven't been addressed, like Jason said, this is the time to do those things. But it's really important for the trainees who are not on the clinical front lines for whatever period of time, that they're not just sitting around doing nothing, that they're actually continuing with their education.
Well, thank you guys very much for taking the time to do this. I think this has been very helpful. And I'm sure offline we'll probably be reaching out for some of the stuff we talked about with regards to conferences and sharing and everything. It's a challenging time, but it's nice to see the creativity devoted towards making sure our learners are still engaged and getting something out of this.
Thank you.
Thank you, Sharif, for inviting us. Yeah.